Chyme leaves the stomach, entering the duodenum. Peristaltic waves propel it through the jejunum. Here, vital nutrients are absorbed through the wall, flowing smoothly through the ileum toward the colon.
Following abdominal surgery, fibrous adhesions can form. This band constricts the small intestine. Gradually, other causes include hernias, tumors, or a twisting of the bowel known as volvulus.
An intestinal obstruction leads to a rapid backup. Fluid and gas accumulate, causing the bowel to dilate through. Below the obstruction, the intestine remains empty and collapsed.
As pressure rises within the swollen bowel, mesenteric veins are compressed first, limiting outflow. Arterial flow then drops, turning the tissue ischemic. Prompt intervention is required.
This CT scan reveals a mechanical small bowel obstruction. Note the dilated loops of proximal bowel filled with fluid and gas. Here, we identify a sharp transition point. Beyond this level, the distal bowel is completely collapsed. Conservative management of a small bowel obstruction focuses on resting the intestines. A nasoc tube removes fluid and gas to relieve pressure, maintain hydration as the bowel gradually decompresses. Here we see an obstructed loop of the small intestine. As the blockage relieves, the bowel untwists. Vital blood flow returns to the ischemic tissue. Peristalsis resumes as the contents move freely.
Ports are placed. The camera enters. Adhesions are released. Unhealthy tissue is removed. The bowel is reconnected. Anatomy is restored.